you? Lovely. Right, so, what if I told you that cardiovascular disease can impact your well-being and longevity every day if preventative measure isn't taking place? I want to talk about Kimberly here, nurse practitioner, who happens to be the daughter of a friend's home resident. And after 9 years in neurosurgical practice, she walked away from traditional medicine. Exactly 1 year ago, she partnered with select lab partners and opened a cardio-metabolic risk stratification clinic. She focuses on identifying inflammation, oxidative stress, insulin resistance, and the risk of cardiovascular and metabolic disease. She has recently incorporated 5 cancer biomarkers to the Revolution Health Panel. Kim's joy comes from building relationships with her patients. Her passion has become educating family, friends, and the community about advanced risk assessment testing. We can all prevent 90% of chronic disease. This is what she brings here today. Come on in, Kim.
Preaching, talking, educating both of them for about a year. I did start the clinic literally exactly 1 year ago this week. And try to break it down because usually when I start talking about it, I get so excited and I'm all over the place. I'm gonna give you a heads up. My speech is, more statistics. Don't nod off because his is very exciting and tells you examples and he walks around and he's enthusiastic. I get kind of the professor's college version of this. So, anyway, yes ma'am.
Could you speak up just a little bit?
Yes ma'am.
Thank you.
Is that better? No? Is that okay? I'm used to being so loud that it makes me anxious to get this close, but if that's better, I'm great. So 1 in 3 Americans suffer from heart disease. We all hear over and over it's the biggest killer. Everybody's dying from heart disease. It's the #1 killer in America. It's #1 killer in the United States, this country, the world. But what scares us is these statistics. Men and women aged 25 to 44 are having heart attacks at an increasing rate. 25 to 44, my daughter. According to the American Journal of Cardiology, heart attacks in this age group have been rising about 2% every year for the past 10 years. So this is not a disease affecting 60 plus, 70 plus, as it used to be. But we do know also, most heart disease is preventable and reversible. What do you think the first symptom of heart disease in 50% of the population is? Shortness of breath, chest pain, jaw and arm pain, or sudden cardiac death? Any other? Shortness of breath, sudden cardiac death. 50%, that's the first symptom, sudden cardiac death. And we know standard studies show standard lab tests do not detect true risk to prevent cardiovascular disease. The standard lipid panel is HDL, LDL, triglycerides, and total cholesterol. We all know these numbers. We've all talked to our doctors about these numbers. We've been getting these lab tests annually for a long time. High LDL levels have been accepted to be one of the top risk factors directly related to developing cardiovascular disease and leading to heart attacks. 70% of people who have a heart attack have normal LDL. Risk assessment and advanced cardiovascular biomarkers are available. Using a standard lab panel to evaluate heart disease is like using an X-ray to evaluate a soft tissue injury or damage to an organ. So in addition to the basic lipid panel that I just mentioned, the American Heart Association recommends use of advanced cardio-metabolic labs for risk assessment. They state the use of advanced labs provide more comprehensive insights into heart health beyond traditional markers. Elevated values of these biomarkers increases risk of cardiovascular disease. Some independently increase the risk of disease. For example, a test called Lp(a). We're actually kind of seeing it in the media here or there, and some clinics around are saying, hey, come here to have this tested. It's not in traditional medicine, but I am hearing the name, I guess, more frequently. This is a genetic biomarker that, if elevated, identifies individuals who are 3 times more likely to develop cardiovascular disease. Current guidelines established by the American College of Cardiology and the European Atherosclerosis Society support once-in-a-lifetime measurement of Lp(a). This test has been available for decades. It has not yet been incorporated into our patient plan of care. Understanding your labs and how they are connected is crucial. So we all know HDL is good, LDL is bad, but what does it mean when you look at them together? What does it mean when you look at 2 different labs together? How are they interconnected? So when these labs are not reviewed with a professional, many patients seek to understand their lab results either on their portal or Google. You know, sometimes we have to look anywhere to find this information, because how often are we sitting down with our provider and going through this information, which probably would take 30 minutes to an hour? Sadly, healthcare is not set up to provide that consultation. And I'm not saying our providers don't want to, they just don't have the time. I know from experience. So knowing what one lab result means does not help you understand your total health, and really doesn't help you understand what the lab means if you're not understanding why it's important, I guess. And for example, one of the advanced tests we look at is the Lp(a). When you have that and you test it and it's elevated, and then you have an elevated homocysteine, which is an amino acid, that puts you at increased risk of blood clots. Neither of these tests are being done in traditional medicine. The risk of stroke and heart attack is doubled when you have an elevated high sensitivity CRP, C-reactive protein, and an elevated Lp(PLA2). Again, those tests aren't being done. When both small dense LDL and triglycerides are elevated, the risk of cardiovascular disease increases synergistically. This represents an atherogenic profile that is more likely to contribute to plaque formation and cardiovascular events. When LDL is high and HDL is low, we've been getting these, the risk of cardiovascular disease increases significantly. We know one is good, we know one is bad, but it is rare for patients to receive the education as to why HDL is good, why LDL is bad, and what happens when they're both not optimal. So we have normal ranges and optimal ranges. When evaluating your lab results, keep in mind normal is a calculation based on a standard reference range, basically the average in a population. So if the group of evaluated in the population are sick, our normal is not going to be optimal. So if we are a sick and overweight population, the normal should not be our benchmark. When you receive your lab results, compare them to optimal ranges. Don't accept the standard reference range or what they call normal, because I've been in my doctor and I love my doctor, but she has said, don't worry, that's normal. But I know it's not normal. and I know I need to bring it down. Optimal lab values are indicative of good health and reduced risk of disease. Normal cholesterol, we're told 200. Keep it under 200. Optimal is under 180. Normal triglycerides, less than 149. Optimal is less than 70. Normal HDL cholesterol. For men, you want it over 40. For women, you want it over 50. Optimal is over 60 for both. Normal LDL cholesterol, goal is under 100. Optimal is less than 70. And the studies show that we have decreased risk of disease when we're using these optimal numbers. The objective of preventive healthcare is to prevent or delay the transition from wellness to illness. All right. What percentage of cardiovascular disease have studies proven can be prevented with a healthy lifestyle focused on managing known existing risk factors? How much disease can we prevent? Chronic disease, if we're doing all the right things that Friends Home is encouraging you to do. 90%. You don't have to have chronic disease if we're doing the right things. That's the hard part. You're up.
All right, so next, all right, so I want to introduce you all to Philip Galinos, who is our health consultant today. He has over 35 years experience in healthcare, helping companies to identify disease states and figure out therapeutic interventions and diagnostics. His turning point was approximately 10 years ago while he was working for Novo Nordisk, a diabetes pharmaceutical biotech corporation, where he saw patients who were diagnosed with diabetes who were not managing their chronic disease state until it was just too late. So Philip, do you want to explain a little bit more on this?
So one of the things I wanted to share with you was Kim kind of explained some of this background and information, but it doesn't come out of just books. It comes out of true application and experience. How many in here have anybody in their family or close friends that are firefighters? Anybody? Volunteer firefighter or full-time career firefighters? Wonderful. Please tell them thank you for your service. Where we really got into all of this and where it all started was with a gentleman, his name is Dr. Robert Saperko. He's a preventative cardiologist. He's actually was at one point part of Boston Heart, but he's now out at Berkeley Heart. He actually started Berkeley Heart, but when he got into preventive cardiology, he was also wanting to give back to his community, so he was the medical director for a lot of fire departments. And he was having conversations with the chiefs of these fire departments, and what they shared with him was, Dr. Saperko, it is hard enough to go to a funeral for a firefighter who's actually been injured and then later died because of the fire itself. The building collapsed, or they got caught in the fire, or from suffocating because of the smoke. But actually, do you know what is the leading cause of death for firefighters? It's heart attack. They actually die going to the fire, at the fire, or leaving the fire from a sudden cardiac event. But here's the crazy thing. Firefighters have to have an annual exam. They are required, fit for duty, to have an annual exam that we all go through. And not only that, but then they have to go through a physical exam. So how are these guys having heart attacks? And Dr. Saperko got very interested in that. These guys are receiving the same type of exams we are. They're using the same biomarkers, the same tests that we use. But yet these guys are dying of heart attacks, and they're some of the fittest guys that are in our community. So how is that happening? So he actually went to a group, I'm sure you probably heard him because of and FEMA paid $3.5–4 million to a grant that he actually went out and studied this. And what he found out was we're actually testing for the wrong things. And he started looking at, historically, back to what Kim was talking about, is what are the biomarkers that are available? What do they really tell us about our health from an optimal health range all the way up, moving into a chronic disease state? And would these be better purpose to give us a better view of what's going on with our health and where we are currently with our health status and where we're heading? And he actually ran that program for probably about 5 years, and then we heard about it and we got involved in it, and we got very passionate about the fact that if this can help firefighters, and it does, they actually are doing this with dozens of fire departments all over the country now, and it's saving lives of these firefighters, then we should be able to use this with anybody, and we need to spread this word. So I think Kim and I are out preaching the gospel now that there are biomarkers, there's testing that gives you a better understanding of your health at current state. But the most important thing is what are you doing about it? And it's back to that 90% of chronic disease can be, or cardiovascular disease can be prevented as long as you have the right knowledge and you're doing the right things. And so that's what we're trying to talk about. The thing that I learned from this, because I came from diabetes, and one of the things I saw in that, but it's the same with a lot that happens with cardiovascular disease, was they were doing educational programs, but those educational programs were based on a very broad view of what do you do within a group of individuals that are all dealing with a chronic disease in the same way, and it was one size fits all. And the reality is does anybody in here think that they're not an individual who's dealing with individual health issues that need to be dealt at an individual level? And so we would tell you that we would ask you to really think about what is the conversation you're having with your doctors and the type of information that you're sharing with them, they're sharing with you, and making sure that you have a more personal approach to what's going on with your health and how you stay healthy. Back to what Kim said is this traditional approach to what is cardiovascular health and wellness in traditional medicine. I don't think Kim in any way, and I want to make sure we all understand this, nobody would ever tell you that having a high LDL or high cholesterol overall is a good thing. That's not what we're talking about. It's that it's just a limited view of your health that doesn't give you a true, complete picture of what's going on, and there are better ways to give you a more complete view of your health so that you can have that right and in-depth conversation with your healthcare provider. Kim would be one of those people that might be having that discussion with somebody. I think the thing that we just all have to realize is that I come from a background of healthcare my entire life. I've had a pretty good life because of that. But here in the U.S., we tend to be focused very much on what do we do when somebody moves into a disease state, whether that be an acute disease state or a chronic disease state. We've got some of the best available therapies and medications in the world, but it tends to have us focusing a lot of time and effort on developing those therapies and those drugs and trying to get those to market and get those to the people that need them, but we're not really spending the time and the effort to have conversations with people and the individual about how to stay healthy. And one of my personal experiences that I wanted to share with you, I have a friend, he's now in his 50s, but and he's still very healthy. But he was one of these guys that in his early 40s was out running races on a regular basis on the weekends. He loved to mountain bike, he hiked. He was always out doing something very physically or physical, and I saw him all the time in the gym. Well, he's probably about, at this point, he's probably 44 years old, and he thought he had pulled a muscle between his shoulders, and the pain just would not go away. And he put up with it for about 2 weeks. And then he started having some other pain, and he finally went to a primary care physician. The thing about Greg, and I'll just tell you his name was Greg, was he felt that he was so healthy, there was never reason to go see a primary care physician on a regular basis. He just didn't do it. But what ended up happening was he did get in touch with somebody that could see him. He actually went and saw my primary care physician. And this guy's named Dr. Myers over in Raleigh, sent him to a cardiologist, and 24 hours later, they had him on the table, open heart surgery. So he went from being this very healthy individual that thought that he was leading this great life of, being in the gym, running, being on a mountain bike, hiking, to how does he end up having open heart surgery? And the reality is he was fortunate enough that he had this pain between his shoulders that gave him an early indication, or otherwise he more than likely would have been the individual that Kim was talking about. His first indication would have been that he had a massive heart attack. And that's when most people, they say that about 80% of all people who are dealing with cardiovascular disease, they find out at the emergency room when they have a heart attack. And those are the types of things that we're just trying to bring to everybody's attention, that the most important thing is to seek as much information about your health and understand the opportunities to learn more about your health through the different types of tests that are out there and the different types of assessments. Take that information, please. We always say this: don't take any information and do anything with it unless you sit down and speak to your primary care physician or your specialist that you're working with, including your cardiologist. But there is the ability to enhance what you're learning about your health, to give you a greater opportunity to actually take ownership of what's going on and have more of a two-way dialogue with your providers instead of just being told this is what you need to do. And a lot of times those conversations tend to be based on a preset one-size-fits-all. So those are the types of things we just want to share with you. I think the one thing that I would just kind of finish with is that healthcare tends to spend a lot of time above the waterline with the what is going on. And that's where, this is back to what Kim was talking about. How much time do your providers have to spend with you? Because most of them are working for these large healthcare systems, and it doesn't limit the amount of time that they have to spend with you. But they spend a lot of time dealing with the what, which is, where are you in some state against a pre-chronic disease or a chronic disease, and how can we manage that? And a lot of times that is through some type of prescription or therapy. We would ask that everybody start turning their attention to the why. Why do these things happen? Why do we progress at different rates into chronic disease, especially cardiovascular disease? Because everybody does it in a different course. Their journey toward, if they're moving into a chronic disease, is very different for each individual. And it's back to what Kim was talking about, is there are all these biomarkers that have to do with what's called oxidative stress, chronic inflammation, cardiovascular risks that are very specific, and then metabolic risks that are associated with cardiovascular disease. All of those have biomarkers that can be tested, and it's information that will help you look at not only what is your current health, but where are you heading and how fast might you be heading toward a higher risk event, and do something about it before it happens. So I think that's about it. So I think it's just, again, back to, we would just ask everybody to kind of take into account that healthcare, I love this. I always talk about this is they call it practicing medicine for a reason because it's always changing. And I think what's going to happen over probably the next decade is what we're talking about will be more practice and part of the common activities that are going on. Because like Kim said, the problem is that chronic disease in the U.S. is happening earlier and earlier and affecting more and more people. And at some point, there's going to have to be a tipping point where we've got to look at it differently. But this is an opportunity maybe for you guys to learn something that others haven't heard about yet. And it is that these advanced tests are available, and use them to actually enhance your understanding of your own health and think more in terms of prevention versus just managing it after it happens. So I don't know if I've got the summary or you're coming back up. Okay. All right. Any questions, comments about this? Does this make sense to everybody? Or is this all brand new? Or because some of this stuff is in the news.
What do you do?
I do. I actually have had the test done.
But what do you do?
Oh, what do I do for the company? I actually am in charge of deciding what tests are being used and how they're applied in the program that we
Who do
do.
you advise, the patient or the doctor?
Both. We actually do both. But we would never advise a patient without first making it very clear that this is educational and awareness, and because we don't treat diagnose to treat. We're going to tell you, you need to take this information to your provider. Does that make sense?
Well, some of those tests you mentioned, the doctor that I had at home did, but here, they don't do it.
I couldn't tell you why they don't, but Kim, you want to
Was it a
speak?
cardiologist you were working
No,
with?
it was a jump too big.
And where did you come from? And now you're here?
Yeah, with common health
Oh, with Cone Health, yeah.
and that.
It really is up to the physician and where they are. There are a lot of doctors that are moving more into what's called functional medicine. And if they're doing functional medicine, which is more holistic kind of view, they will start applying some and having some of these tests run. Others are very linear in their thought. They're looking at trying to figure out what's going on.
The insurance paid for it at home, but there's no.
Yeah, that's a big part of it right now is that how some of these tests are being used in such a way that the doctors can ask for them and they do get reimbursed through Medicaid and through health insurance, others are not. So that's a big part of it too.
And some of them are approved by insurance. I was meeting with a cardiologist in Greensboro. He said he can get them approved if somebody's had a heart attack. So not used as preventive, but used as follow-up, I guess.
Yeah, there's a test that we do called NT-proBNP. It's actually looking for an enzyme that's put off by your heart muscle activity. They use it in the hospital to confirm that you've had a heart attack. That's the only time it's typically routinely used, but we've repurposed it. Dr. Saperka repurposed it because you can look at lower levels of that enzyme and realize the heart is starting to be stressed. And so there is a different way to use it, but in most cases, the one that's reimbursed is in the emergency room to prove, congratulations, you've had a heart attack. So, yes?
How do we as patients ask for tests that might indicate more of what you're saying? Or is there a way to do that?
Go ahead.
So when I went to my doctor, when I learned all about this, we had a very candid conversation, and part of it was when I was talking about the C-reactive protein, and she said, well, if you find out, what are we going to do with it? And that's kind of traditional medicine's response, and the fact that most insurance will not reimburse it, they're not ordered. Those are her words. I'm gonna try and keep that.
Well, is there a way we can get a list of the exact words to ask for?
Yeah, and I can send out also, I've had put up here a list of tests that you should receive. And this is the cardiovascular part of what we do. There's also metabolic, insulin resistance. It's a whole nother bag of worms. But of course we didn't want to tackle too much today.
I would mind a list of everything possible to ask.
And there's also places where you can get them done. If your doctor doesn't want to order them, which is why we have the clinic, that's one of the reasons we're doing it, is because one of the things we believe is not only do you need to have these tests, you need to understand them. And if somebody's not talking with you after you have these tests and spending time with you, how beneficial are they and how motivated are you going to be to make changes based on seeing a number in a portal? There are places, functional medicine, integrated medicine, there are people who are up on the science of realizing or even following guidelines, the importance of these things. My doctor, when I asked her about LP(a), she said, I'm just not well versed in it, and I don't even think I learned it in medical school. So there is a transition of knowledge, and truly I adore my provider, and I appreciate her having these conversations with me, but there's education to be had for everyone.
Yeah, I have a doctor, he actually didn't become a doctor, and he went to med school when he was 40 years old. He left out of industry and became a doctor, and I was talking to him about this, and he knew all about it. And he said, as a matter of fact, Philip, I would love to be more engaged with what you guys are doing, but in cases where I think there is the likelihood that this could be beneficial, he says, but I have to find the right instance to introduce this in such a way that I don't burden patients with having to pay for tests that unfortunately are not being covered by their health care. But he will, LP(a) is one that he orders on a regular basis for certain patients that have high blood pressure and high cholesterol. He wants to know if there's LP(a) because it does increase the possibility of cardiovascular disease significantly. And just FYI, here we are talking about trying to be more preventative, but if you have LP(a), if it's part of kind of your genetic makeup and it becomes part of what we see in the blood system, there's not really anything you can do about it. It's there. And what you do with the rest of your health-related behavior that can reduce the other risk, the LP(a) is not going to change. There are some actual companies that are working on therapies and a drug that's currently in clinical trial to reduce LP(a). But knowing that definitely creates an interest in trying to reduce all the other risks. And so that's where we would suggest that knowing that is one that you definitely want to know if you have or not. So,
What do you think?
yeah, and if you have it, there's a good chance that somehow it's been contributed to family members, so you need to be aware. Any other questions? Yes?
So your clinic works with heart disease and insulin resistance?
So it's a cardio-metabolic clinic, which means we are looking at the root causes and doing a host of labs that look at inflammation, insulin resistance. Again, all of these things we're not getting in our annual exam, but we know are the root causes to diabetes that lead to chronic disease, and that's really the focus of functional medicine. The focus of integrative medicine is to look at the root cause, so we're not diagnosing with labs. And that really is, you know, I don't even like to say diabetes, I like to say insulin resistance, oxidative stress, inflammation, because that's all what everything's growing from.
So Dr. Serperko, one of the things he found out through the FEMA study that he did was that there was this very much fixation on cholesterol levels, which again, please do anybody walk away and think that I said, hey, don't worry about your cholesterol, go eat all the, you know, bacon you want to. Cholesterol is a bad thing, but it's a very limited view of what's going on, and the nexus point where small, Kim was showing you small dense LDL, which is part of your LDL cholesterol, along with LP(a), a nexus point that sends you off into cardiovascular disease is actually insulin resistance. So what they're finding out is insulin resistance is that nexus point that you start moving into different types of chronic disease states. So if you understand insulin resistance and you can manage that along with the other risk factors, then everybody thinks insulin resistance is what's making everybody fat. And I'm not saying it's not, but what I'm saying is insulin resistance is the next point for a lot of cardiovascular, diabetic, chronic kidney disease, all of these things, and understanding and managing insulin resistance along with all these other things that we talked about today is important.
Are you doctors?
No, I am not. I just stayed at Holiday Inn Express. No, I'm not. She is. She's the practitioner. That's your doctor. She's a nurse practitioner. I have 35 years of actually research and development where I spent time figuring out disease states and then figuring out how to create a diagnostic to understand what was going on with that disease state, and then figuring out how to build a therapeutic for it. So
no doctors are associated with your whatever.
Dr. Serperko.
oh, well, Dr. Serperko, yeah, we have a number of
Is it
doctors.
local?
And Dr. Turner is local.
Dr. Turner's local, Kim's local, Dr. Serperko is actually in California now. But he was the one that basically is the, I guess, the catalyst that had us all start thinking about this in a different way and how to use. Our company does basic clinical testing just like any of these other companies, but we were feeling like, what benefit are these tests doing for everybody? Because we keep doing all this testing and everybody in the country gets more and more unhealthy. So there's got to be a better way to kind of look at this. And fortunately, our founder, just to let you guys know, our founder is one of the original guys who started LabCorp. And he realized there was a better way to go about practicing what we do. And he and Dr. Serperko became very good friends, and Dr. Serperko came and told us what he's doing, and we're like, okay, we got to help this guy. And that became kind of our mission, was to help Dr. Serperko help firefighters. And we got involved in his firefighter program, and we realized if we can help firefighters, we should be able to help everybody with this. And so that's kind of where we're out preaching awareness that there's a lot more out there that can help you be in control of your health and have the discussion you want to have with your physician than just what is normally provided to you.
And the medical advisory board
Yeah.
are all local
Physician.
cardiologists, endocrinologists, except for Dr. Serperko, who's in California.
And Dr. Turner is in functional medicine. Yep.
So, as part of your practice, once a patient comes in and has the testing, then do you guide them through some life changes, diet,
Yes.
exercise, and so on? Is that part of it?
We spend a lot of time and make sure that we do it in such a way that we do clinical education on all the testing and not talk about each test, but talk about how those tests interplay with each other to create a specific profile for you as an individual. And then we give you access to what are called integrative health coaches. This is, I don't mean, I'm almost asking rhetorical, but does everybody understand where the health below your shoulder starts? right here. A lot of what is going on with your metabolic health and what's going on below your shoulders has to do with anxiety, stress, sleep, and how do you manage that anxiety, stress, and your sleep patterns. And a lot of people use food, they use alcohol, they use other things to kind of manage what's going on above the head. Well, eventually what happens is it starts to affect what's going on below the head. And that's what we do. Our integrative health coaches try to help people understand mindfulness, how to handle anxiety, how to handle stress, how to be better at their sleep patterns, and understand that those have direct connection with and their trigger mechanisms to what people are doing and their behaviors. Back to what Kim said, 90% of chronic disease could be prevented. Well, that 90% is starting up here. That makes sense?
And they're proving now, which Friends Home addresses, is the importance of social interaction.
Yes.
And we know that that is crucial.
That's a huge trigger. We saw, and this is one of the reasons we got into it also, is we saw this huge jump in chronic disease progression during COVID. Why was that?
Isolation.
Isolation. People were isolated. They were starting to have mental health issues. They were feeling lonely, and they did everything that they shouldn't be doing. But, okay. Another question?
So is there contact information how to find you in local?
You're welcome to see us, but most importantly, the education is really why I'm here. Definitely not a sales pitch, but we can also help you find local providers. We just want to make sure you're aware of what's available.
There are local providers in this area that understand exactly what we just spoke about and can speak to it even better than we can. What is the group, Robin Hood?
Robin Hood Integrated.
Robin Hood Integrated is out of Winston-Salem. There are groups here in the Greensboro area, but they're very specific and they're very few that are really focused on this right now. But we do think it will start spreading. But it's just one of those things where we would like to share with the general population that they should be asking for it. So, okay.
I'm curious about the relationship to of prevention with family genetics and heredity. Just a quick example. One of my grandmothers had a major heart attack when she was 50. She lived to be 89. And later, my mother had the same, well, a heart congestion as my grandmother had, but she didn't have a major heart attack. But I'm just curious, you know, at 50, and of course this was before a lot of things were done.
Yeah.
But what do you do to be preventive?
Again, we would say try to get, with what's out there now, try to get in front of it with some of these preventative testings or these early determinate health risk testing done. But one thing we all have to just accept, there are certain things are in our genetics that we pass from one generation to the other. And if there was a congenital heart defect, I don't know if anybody ever remembers a guy named Jim Fix. He was one of the greatest marathon runners in the country forever. And he died running a marathon because he had a heart defect that eventually gave way and his heart tore. But everything else would have shown up fine. But he had a heart defect. The things we're doing are not really going to speak to that, but those are aberrations. Most cardiovascular disease is based on we don't treat our bodies well. But we can't catch everything, but we can do what we can do. If that answers your question.
And also, standard guidelines, if somebody says a family member had a heart attack at 50,
yes,
we're much more aggressive. Traditional medicine, we are much more aggressive with the testing, and maybe not the advanced testing, but just in general watching those patients aggressive in terms of following you and how you're doing, because that is literally, if you look at tests on nursing tests and medical boards, that's one of the questions. You know, what if somebody has a family member who's had a heart attack at 50, and it is following them on risk?
Yes, ma'am.
Do you have a list of places we could go for these diagnostics?
I can create that and
Yes.
send it, absolutely. Where you can talk to people or what, absolutely, happy to do that.
And it's going to be a broad range. I mean, we'll send you to the people that know these tests, know them very well, will tell you when and how you should use them. But you're going to find other doctors who just really, this is not part of their, you know, they've been out of med school for a long time. They've got a certain process by which they follow, and these are just not part of it. But I think what you're going to find is more and more, the actual interesting thing is more physicians are coming out of what's called DO school than the MD school. And DOs are actually functional medicine doctors. And I've got a friend whose daughter's in a DO school right now, and I started talking about this in front of her to her father. And he's like, I don't know what you're talking about. And she walked over and said, Dad, let me explain this to you. They're actually being trained about this stuff in med school now, or at least in what's called DO school.
It's kind of how I tried to explain a PA versus an NP. There's a medical approach, and then there's, and this is changing also, but that kind of the holistic, you know, I have to explain that and be able to talk about it. And this is another example, NP and DO, but approach to medicine.
I don't want to do this to Kim or to you guys, but there's some people who want to hear somebody play a guitar.
Oh.
And I think we're in the way of him setting up.
Yeah.
So I don't want to cut it off. You guys have been wonderful. These questions have been excellent. You guys really do seem